orthopedic surgeons at Vermont Orthopaedic Clinic. My specialty is hips and knees, which mostly means hip and knee arthritis, which in terms of the surgery I do means mostly hip and knee replacements. So I'm going to talk a lot about hip and knee replacements in general, hip and knee arthritis in general, and then specifically a little bit about what I do. Please feel free to ask questions at any point. My slides are kind of meant to give a little bit of an overview, but get people to ask questions. So just raise your hand. I will repeat your questions so that they are heard on the microphone, so everybody in the room can hear, hopefully, and so the video can hear. So minimally invasive joint replacement. What is it and who is it for? The quick answer to that, in my opinion, is it's a slightly better version or progressed version of what we first had in terms of hip and knee replacements, and it's for just about everybody to one degree or another. It's a difference in the actual implants that we use. So there are some better, more modern versions of implants than the ones that were invented in the 60s and 70s. Obviously, things have progressed. There are partial knee replacements. There are more bone-preserving implants. There are some big differences in how we do these surgeries, but there are a lot of differences in how we take care of patients before, during, and after these surgeries. The differences in how we take care of patients are probably just as important as the differences in the surgeries and the parts that we're using. So just a little bit about your knee. Your knee is three bones: the femur or the thigh bone, the tibia or the shin bone, the patella or the kneecap. When we think about arthritis of the knee, we think about the knee and divide it up in three compartments: the medial, or the one towards the other knee, the lateral, or the one towards the outside, and the patellofemoral or kneecap compartment in the front. And this is just a little cartoon. So thigh bone, shin bone, kneecap. So what symptoms do people get with knee arthritis? Well, pain is the most obvious. It's usually associated with activity, but also a lot of people complain about pain when they first get up. It is often centered around the thigh, but can go up and down the leg. Often goes down the shin. That's a very common complaint for someone with knee arthritis. Stiffness is one of the hallmark symptoms of arthritis, especially when people get up in the morning or get up from sitting for a period of time. Grinding, popping, catching, clicking, locking, all of those things can occur as those surfaces wear out. What arthritis is, or at least when I use the term arthritis, what I mean is wearing away of the surface cartilage in the joint. If you ever opened a chicken leg or a turkey leg, you see that shiny stuff on the ends of the bones. We have the same stuff on the ends of our bones. And when that wears away, it causes a lot of these problems and a lot of these symptoms. The body's natural response to inflammation in the knee, whether it's from arthritis or an injury or any other thing, is to try to calm down that inflammation. One of the ways it does that is it produces more of the normal fluid in the knee. There's normally fluid in our joints that lubricates the joints. When people have arthritic knees, often they have some swelling or fullness in the knee because they have extra fluid. Occasionally they have so much extra fluid that it's really dramatic, and that's when people say they have water on the knee and they end up getting their knee drained and things like that. Your knee can hold a remarkable amount of extra fluid. People can get feelings of instability as a result of pain in the knee. It hurts, you can't keep your weight on it, you subconsciously take it off, and people can actually fall down and have the knee give way, or they actually can have so much damage to the knee and so much wear and tear that they can actually have some instability if it gets to the point where things are worn down and worn out to the point where they're mechanically no longer structurally sound. It's essentially, like I said, caused by loss of or damage to the surface cartilage. There are a whole bunch of reasons that that can happen. The most common is osteoarthritis or wear and tear arthritis, or we don't know why arthritis. As it turns out, there is actually a lot of inflammation involved with osteoarthritis. It's probably more than one problem as well that ends up with the same result. We just don't understand it as well as I think we're going to eventually. Some other types of arthritis, inflammatory arthritis, the best understood, most common being rheumatoid arthritis, we do understand pretty well in terms of what's the feedback that results in damage to the cartilage. Regardless of how things happen, they all kind of have the same result. Here's a cartoon of end of a thigh bone with the cartilage worn away, and you literally end up with missing cartilage down to the bone and eventually start wearing the actual bone down. If you wear enough bone down, you can actually get a deformity of the knee. So people who are very bow-legged that didn't start that way, people who are very knock-kneed that didn't start out that way, typically have arthritis, and they've worn one side of the knee more than the other, creating that deformity. There are lots of other causes of knee pain. Just because your knee hurts does not mean that you have arthritis. Probably the next most common cause is a tear of the meniscus, or the little cartilage pad in the knee. There are two different types of cartilage in the knee. There's that end surface cartilage like the chicken bone, and then there's these two specialized little cartilage pads. They're separate structures. This is looking down at the top of the shin bone. And we've pulled the thigh bone off the shin bone, we're literally looking down at the top. Two little semicircle C-shaped cartilage pads. They're a different type of cartilage. Those can be and often are damaged, and that can cause pain. Believe it or not, your hip can make your knee hurt. You can have no problem with your knee at all, have no pain in your hip, but only have a problem in the hip, and that has to do with the overlap of sensory nerves, where they connect, and how those signals get to your brain. And people can have what's called referred pain, which is entirely from the hip, but shows up as pain in the knee. Tendinitis, bursitis, anything-itis, anything that is a tissue can get inflamed or damaged. That's why the term arthritis is probably not the best term. We should be more specific most of the time. When we're talking about it, osteoarthritis, rheumatoid arthritis, all arthritis means is joint inflammation, and it can happen for a whole bunch of reasons. Tendinitis, bursitis, things like that are not actually in the joint typically, but they're around, in and around the knee itself, and can cause knee pain, and often do. So then there's the hip. The hip is a simpler joint in terms of what makes it up. It's a ball and socket joint, the top of the thigh bone, or the femur, and the socket in the pelvis, or the acetabulum. It's lined with the same exact smooth cartilage surface. There are lots of things around the hip that attach the femur to the pelvis, muscles, ligaments, tendons, all kinds of things. Just like in the knee, those can be damaged and cause pain and have different problems. There are lots of things in and around the hip that can cause problems, but arthritis is probably the most common cause of hip pain. There is an analogous, similar type of cartilage structure like the meniscus in the knee that's in the hip that can cause pain as well. So a big part of my job is figuring out where's the pain coming from, and then how do we make it better. Similar symptoms, pain, especially with first couple steps. Typically, hip pain shows up in the groin in the front. It can also show up deep-seated in the back, occasionally on the side, although that's most commonly bursitis. It can occasionally, like I talked about, show up entirely as knee pain. Very commonly, people feel it in the groin, running down the front of their thigh to the kind of the front outside part of the knee. It may get so severe that it causes pain even without moving. That's a pretty advanced case of arthritis usually. It similarly causes stiffness and a pretty characteristic limp. People who kind of limp to one side, usually it's because of their hip. Stiffness in the hip quickly can start to lead to some trouble with putting on shoes and socks and getting into funny positions where we do certain things. Knee stiffness has to progress further before it really starts inhibiting people kind of on a daily basis. Both problems are wearing away of that cartilage surface. Can be from a whole bunch of things, that wear and tear osteoarthritis. People ask me every day, why do I have this? How did I get it? You mostly have your ancestors to thank. I think it's kind of like shingles on your roof. You can buy the 20-year shingles, you can buy the 40-year shingles, you can get the slate roof. They all last different periods of time. your cartilage kind of does the same thing. Some of us have cartilage that's programmed to outlast us. Some of us have cartilage that only lasts till we're 40. We can't do anything about that. There are other things that we can do something about. Some of the inflammatory arthritis problems, we have really good medications nowadays to slow down or stop those inflammatory processes. And that's what rheumatologists do. That's the main thing in their practice, is treating folks with those medications. Trauma, we can't always stop people from being injured, but we usually can't fix an injury 100%, but we can make things a lot closer to normal. So fixing broken bones, setting broken bones, obviously relocating dislocated joints, things like that minimize the subsequent development of arthritis. They usually don't entirely prevent it, though. Loss of blood supply is something that not too infrequently affects the hip. If people have a problem called osteonecrosis or avascular necrosis, which can occur for a whole bunch of different reasons, it can lead to damage to the blood supply of the ball and socket of the hip. Bone is a living tissue, just like muscle tissue and everything else. Just like you can have a heart attack if the blood supply to the heart is damaged, you can have a bone attack if the blood supply to the bone is damaged. If that happens in the middle of a bone, it doesn't really cause any problem. If that happens right under one of the main weight-bearing joints in the body, it can cause some big problems. That bone can go on to collapse, damaging the cartilage surface kind of from the underneath up, so to speak, and that can lead to the need for hip replacement. Sometimes we know why that happens. Steroid medications, certain endocrine problems, excessive alcohol can all cause that. Sometimes we don't know why it happens. It just happens for no reason. Abnormal development of your hip socket. Just like Labrador retrievers can have hip dysplasia, we can too. That typically leads to a socket that is not as deep as normal, which puts more pressure on the cartilage of the ball because it's not spread out over as great an area, which leads to earlier arthritis than people would have otherwise. There are a whole bunch of other things. Muscles, tendons, ligaments, bursas, which are fluid-filled sacs that can cause pain around the hip. A thing that often causes pain in or around the hip but doesn't in the knee is back and spine disease. Pinched nerves in the lumbar spine or the low back, and this is supposed to be a cross-section of the low back and demonstrating pinching of nerves, can and often does cause pain in the buttock, low back, groin, thigh. And again, one of my biggest jobs and something that I do every day is figure out where's the pain coming from. And is it from a nerve in the back? Is it from the hip? Is it from all of the above? You can get catching, locking, clicking in the hip. It's a little less common than in the knee. So surgery should always be the last resort. I say that every day. I spend more time telling people not to have surgery than I do anything else. I'm a surgeon. I like to do surgery. I wouldn't do it if I didn't think there was a role for it. But if you can avoid it, you should. Most of the time, people can. Occasionally, they can't. When they've reached that point of last resort and they've tried everything short of surgery, that's when someone's a candidate for a joint replacement surgery. There are not a whole lot of things that I treat where I tell people you need surgery. If they fall down, break a bone, it's sticking out of their arm or their leg, I tell them you need surgery. Hip arthritis, knee arthritis, stuff like that, you never need to have surgery. It's an elective surgery. You're either a candidate for it or not. Occasionally it's reasonable to choose not to have surgery and use a wheelchair or not walk. Not often, but sometimes it is. So we have a whole lot of treatments aimed at decreasing the pain, managing the symptoms. Unfortunately, we can't cure the problem yet. I think we probably will. I think at some point we'll figure out how to turn back on cartilage growth. Unfortunately, once we finish growing at this point, so when you're in your teens or early 20s, your cartilage stops growing. Once it stops growing, it can't be repaired. If you wear it away, it does not grow back. It doesn't heal, it's just gone. So everything we have, including joint replacement, is aimed at treating the symptoms. Joint replacements don't actually cure the problem, if you think about it. Curing the problem would be regrowing the cartilage. We can grow it in the lab, we can do some limited things clinically, but we can't replace all the cartilage in a worn out joint, unfortunately, yet. So, kind of the first line thing that people do and have often already done by the time they get to me is activity modification. It's the old, doc, it hurts when I do this. Well, don't do that. People figure out before they ever get to me, I can't run up 3 flights of stairs anymore. I can't go out for a jog. I can't do any number of things. It's when they are not doing enough things that most people come in and see me or someone else and say, geez, this is really affecting my life. I can't do the things that I want to do and need to do. That's when we start with things like anti-inflammatory medications. Advil, Motrin, ibuprofen, all those types of medications are a class called non-steroidal anti-inflammatory medications. Tylenol is a different class of medication, and unfortunately lots of people for different reasons can't tolerate the non-steroidal anti-inflammatory medications, so Tylenol or acetaminophen is one of the best other medications that we have. There are a bunch of nutritional supplements. People ask me all the time, does glucosamine chondroitin work? Probably. There's no conclusive good study. There's a couple suggestive studies. You kind of got to take those with a grain of salt because the best ones were sponsored by a company that makes the stuff. But I have enough patients tell me it makes a big difference for them that there's probably something to it. Physical therapy, weight loss is the only thing that's been shown to slow down the progression of hip and knee arthritis. Everything else can help manage the symptoms, but it's the only thing, excessive weight's the only thing we know of that we can affect directly that speeds up the progression of the disease, and therefore losing weight is the only thing we know of that can slow it down. Instant weight loss is using a cane or a crutch or a walker and basically taking weight off the joint. Injections, steroid injections, cortisone type shots. Cortisone's a brand of steroid, but it's like Kleenex. We use that term or we use that brand name often when we're talking about steroid injections. They can and do work very well at decreasing inflammation in the knee. They can work in the hip, but usually are pretty short-lived, harder to give, and are not as useful in hips. There's another class of medication called viscosupplementation. It's basically, I think there's about 6 brands now. They're a synthetic version of the normal joint fluid that's in a joint. It's anywhere from 1 to a series of 6 injections. The couple brands that are 1 injection are actually out recently, and it's meant to replace the abnormal joint fluid that's in the joint. The idea is kind of like an oil change. You take out the dirty or contaminated fluid, although we don't always have to take it out, and we replace it with good fluid, so to speak. And that can, both of those types of injections can give significant relief for a significant period of time, especially for knee arthritis. Unfortunately, they don't stop the progress of the disease. Most people still, if they were going to wind up being a candidate for surgery, do, but often it's several years later, which there's some advantage to that, and I'll talk about it in a second. So what do we do for arthritis? Occasionally, arthroscopy or a scope, sticking in small instruments and cameras that magnify the inside of the joint and taking things out. Arthroscopy is really good at taking things out. It's not good at putting anything back. So we can't put cartilage back that's missing. We can take out pieces that have broken off or torn off or are blocking things or getting in the way. So occasionally, if that's the specific problem we're treating, arthroscopy works well. Osteotomy is cutting the bone. Cutting and repositioning the bone is something that can occasionally be done to take the pressure off of one part of a joint and put it on the other. We take it off the part that's worn and causing pain. We put it on the part that's not worn and therefore for some period of time won't cause pain. That's more of an option for someone who's not a good candidate for a joint replacement and has a specific pattern of disease. So then there's joint replacements. There are a whole bunch of different kinds. There's unicompartmental knee replacements, which when we think of those 3 compartments of the knee, it replaces just one of those 3 if that's the only one worn out. There is something, the newest version, it's about 5 years old now, that replaces 2 out of 3. And then there's a complete knee replacement, which is a total knee replacement that replaces 3 out of 3 of those compartments. There is such a thing as a hip hemiarthroplasty. If just the ball is worn out, we can replace just the ball. That's more often done for hip fractures or for that problem, osteonecrosis, where you get death of the bone of the ball. And then a total hip replacement or a complete hip replacement, replacing the ball and socket. There are lots of different versions of all of those. There are lots of different versions of total hip replacements. There has been a lot in the news in the last couple years about hip resurfacing. That's just a version of a hip replacement with some parts that are a little bit different. Oops, sorry. So we resurface the medial or inside part of the knee towards the other knee, the outside or lateral part, and the kneecap joint. There are a bunch of different materials used, but in general, there's metal on the end of the thigh bone, metal on the top of the shin bone, a piece of plastic in between, and a piece of plastic that goes on the back of the kneecap. Lots of different companies make these things. They are all a version of that. In fact, the FDA has not approved anything but that for use in the United States. So there's no ceramic knee replacements in the United States. There are no metal-on-metal knee replacements. There are some of those things for hip replacements. We only replace the surfaces of the bones. One of the things that people often ask about is do we just cut off the thigh bone midway and cut off the shin bone midway and replace everything in between? That can be done. It's done for tumor surgery and some other extreme kind of drastic problems, but in general, we try to leave everything. We leave as much bone as possible, so we just replace the surfaces. We leave the ligaments, the tendons, the muscles, everything else around your knee. So you replace the worn out surfaces, you get to keep everything else when we do knee replacements. Hip replacements are similar in that we replace the socket with a metal socket. Typically, there are a bunch of different versions of the liner of that metal socket, however. There's a bunch of different versions of plastic or ultra-high molecular weight polyethylene, which is the most commonly used one. There's also metal liners. If you've watched the new TV at all lately, I should say, you've seen the commercials for the lawyers suing everybody. That's because of metal-on-metal hip replacements. I don't use those. Most people don't right now because of that problem. And then there's ceramic liners. There are there's a metal ball, and then there's a ceramic ball. So there are combinations of those different things. By far, the most commonly done is a metal ball with a plastic socket inside a metal shell. That is the right choice, in my opinion, and in most people's opinion, for most people. But occasionally, there's something better for certain subsets of patients. So here's just an extreme example of a hip replacement. This person's lost not only all the cartilage, but also the entire ball of the ball and socket, and has kind of created a square peg in a round hole because they've worn out all the bone, and that's afterwards after replacing it with an anchor or a stem that goes down the top of the thigh bone that literally is just a spot to anchor the ball, a new socket, and what you can't see on the x-ray there is the plastic bearing that goes in between. So that's just a picture of complete knee replacement. End of the thigh bone, top of the shin bone, that blank or space in between is where the plastic bearing surface is. Here are some pictures of partial knee replacements. So this would be the outside of the patient, this would be towards the other knee, and this is when just this compartment has been replaced. This is the opposite. This is outside, this is towards the other knee, and just this lateral or outside compartment is replaced. And here's a picture of just replacing the kneecap compartment. All three of those use a plastic bearing, again, that goes in between. Here's a picture of that 2 out of 3 replacement. The purpose of this, and what the makers of this will tell you is the advantage of it, is it preserves all the ligaments in the knee. Routinely, a complete knee replacement gets rid of one ligament, the anterior cruciate ligament. Some surgeons get rid of the posterior cruciate ligament. If that ligament's not there, it's an easy decision. You have to replace it. If it's there, that is the posterior cruciate ligament, I typically leave it, but there's some debate over which is the best way to do that. Would you ever replace just part of the knee? Well, I tell people the good news is you keep the rest of your knee. The bad news is you keep the rest of your knee, and that can still wear out. It is definitely a smaller incision. It's a little quicker recovery. It's more normal, natural movement, and there's some subjectivity to that, but every patient I've ever had who's had a partial knee replacement and a complete knee replacement, either one then the other on the same side or one and another on different sides, they all have a feeling that the partial knee replacement feels more normal. That's probably because the ACL, or the middle crossing ligament, front crossing ligament in your knee, has some nerve endings in it that kind of tell your brain where your knee is and where it's moving and how it's moving in space. So that's probably why it feels a little more normal. It also has, on average, a little bit better range of motion. A knee replacement, unfortunately, is not like a knee that's good as new. It's closer to good as new, but it's not as good as new. So the worse someone's knee is, the more difference we can make by doing a knee replacement, because we can get it a lot closer or a lot further from where it is to closer to good as new, but it's never quite normal. They don't move exactly like a normal knee. Most people have a subjective feeling that it feels a little bit different, although the pain is gone, and they don't have, on average, the same range of motion as a normal knee. Again, the big disadvantage of the partial knee replacement is they can still wear out the rest of the knee. I think partial knee replacements are a great option for two categories of people. All of these replacements are mechanical, metal and plastic, or metal and metal, or ceramic parts. They all, unfortunately, therefore, can wear out. Most people, the next question is, well, how long do they last? It's more like tires on a car. It's the number of miles, not the number of years. But on average, the ones that were put in long enough ago to watch them for a long time, this is hip and knee replacements, 20% of them had worn out in 20 years. So only 80% of them lasted 20 years plus. The current technology is better. They, at least in the short term, are showing that they're wearing out less or wearing less and should last longer. The plastic has changed in the last 10 years or so, and at least in the lab, it lasts twice as long. I doubt it's going to turn out to last twice as long in people, but it's definitely turning out to last longer. Best guess that I have is that in most people, they'll last 25 years instead of 15, which is the old number. So 90 to 95% of them lasted 15 years ago, the ones that were done 20 and 30 years ago. Another way to look at all those statistics is there's about a 1% chance per year that adds up additively that you wear out part or all of it and need it redone. So at 20 years, there's a 20% chance. At 30 years, there's a 30% chance. So partial knee replacements, I think, are good for people who only wore out one part and they're a little bit young to consider a knee replacement because it's less surgery, it leaves the rest of the knee, and it's pretty easy to change that to a complete knee replacement once that wears out or the rest of the knee wears out. They're also great for people who our best guess is they've already worn out their knee as much as they're going to. If someone's 85 years old and they've only worn out one part of their knee, chances are that's all they're ever going to wear out, and that surgery is the only surgery they'll ever need. People who are in between, it's debatable, and it's a decision that I have patients make with me if they're kind of right in between and a candidate for both. So, again, the advantages of that are it's a little faster in the operating room. There's a little less bleeding because it's faster, and it's less surgery. We've taken a lot of the ideas and techniques from partial knee replacements and started using those in complete knee replacements as well. Minimally invasive knee surgery or knee replacement surgery really started with partial knee replacements. It's being used extensively, and I use it extensively in complete knee replacements now too. Some of the techniques and the ideas. So it's a smaller surgical approach. I hate to talk about lengths of incision because that's not really what matters as much as what we do underneath, but it's usually a smaller incision. This little cartoon's meant to show you kind of the average standard old-fashioned incision for a knee replacement. The little blue line with the dashes is really about what a typical knee replacement incision is now. Again, it's more important what we do underneath. We cut less of the tendon, we cut less of the muscle. We also do some things differently during surgery. The traditional old-fashioned way to do this was to turn the kneecap around 180 degrees, dislocate the knee, and look at all three parts of the knee all at once. You could see it from across the room. Now we realized you don't need to do that. We just look where we're working. Turn the kneecap on edge, but not all the way around. Bend the knee so we can peek in, but not fully dislocate it. And all that just makes it hurt a little bit less and hopefully makes people get better a little bit faster. And I think it definitely does, or I wouldn't do it that way. So it's less pain, quicker recovery. Potentially, no one's proven better range of motion, because part of what keeps people from getting their range of motion after a knee replacement is the scar tissue that forms from surgery. Part of it is if they had a stiff knee before surgery, their ligaments, muscles, tendons, all those connective tissues are stiff. We don't replace any of those, they stay stiff, so it's hard to overcome that preoperative stiffness. It is a little more technically difficult, although I would say that pretty much every knee replacement surgeon now that's still doing knee replacements is using at least some of these techniques, even if there's someone that stands up and argues against them. There are two brothers in the Midwest that always speak at panels when we go to our medical education meetings, and one always speaks for less invasive or minimally invasive knee replacement, and the other one argues against it. But even the one who argues against it agrees, well, yes, I use a bunch of those techniques, but I think taking it to the extreme is not a good idea. So it's changed over the years. This is just meant to show, once you get through the skin and the muscle, where we go inside the knee. So traditionally, this actually would go all the way up, and this is meant, this cartoon, this is a kneecap, and this is meant to show the quadriceps tendon, or the main thigh muscle tendon. So it's really a difference in how much of that we cut and how far up we cut. It is definitely something that has evolved over a long time and is still evolving. It is a continuum. Even that guy that argues against minimally invasive or less invasive surgery uses some of the techniques, and then there are people that take it to an extreme. Everyone else, like myself, is somewhere in between. It is smaller incisions and a smaller scar, but that's not what's important, in my opinion, and actually in most patients' opinion. By the time people get to the point of having a knee replacement, most folks are not worried about a scar on the front of their knee. It does spare or do less damage to key tendons, ligaments, muscles, and tissues around the knee. It's very important that it uses traditional or proven implants. You never want to be, in my opinion, the first person to have the latest, greatest, newest thing, because it's not proven. These things have evolved over years and years. Hip replacements, the current modern hip replacements that are an anchor, a ball, and a socket, were developed in the 60s and have been improved slightly every year since. Knee replacements shortly thereafter. They're really good. They have a very, very high rate of success, and you don't want to be the person who has the newest, latest, greatest thing. I think the metal-on-metal hip replacements are a good example of that. The one that's been recalled and has caused all kinds of problems, I never used because it was new. And I don't want to use anything until it's been around for a while and proven. So even though we do the surgery differently, we use parts that are proven and have been around long enough to know what they're good for and what they're not good for, and what the problems are with them, and what the advantages of them are. It is some changes basically in the instruments that we use and the techniques during surgery. So instead of looking at everything at once, we look at one thing at a time and put things together. So I'm getting rid of the things that are not as important and kind of emphasizing the ones that I think are. Minimally invasive hip surgery, very similar. There are a whole lot of different ways to do hip replacement in terms of how you get into the hip. From the front, from the back, from the side, different versions of all of those things. But essentially, no matter how you go in, it's the same procedure once you're there. We replace the ball and we replace the socket with mechanical parts. So very traditionally, incisions were 1.5 to 2 feet long. Again, we looked at everything all at once instead of just where we're working, and it was a really big deal. In fact, when hip replacements were very first introduced, we purposely would cut the top of the thigh bone off, detach the main muscles that hold the hip in place, and put it back at the end. Put people in a brace or a cast. They would typically spend a couple weeks in the hospital. They would spend 3 to 4 months on crutches, and the whole thing took a tremendously long time to recover from. It's a lot different now. My average patient leaves the day after or the second day after surgery. You can put all your weight on it right away, and we want you to. You use crutches, canes, walkers, or nothing, depending on how comfortable or uncomfortable you are and how your balance is. Takes about 6 to 8 weeks to be most of the way recovered, kind of over the surgery part. Takes a lot longer to be over the arthritis. So to regain the strength and the range of motion and the endurance, that's lost over a long time, usually years. And while people get over the surgery pretty quickly, and this is true of hip and knee replacements, takes them a lot longer to get over the disease. So in general, I tell people, you'll be about 85, 90% better in 2 to 3 months. You'll be as good as you're going to get in a year or more. So for the last bits of strength, the last aches and pains and swelling and all that to go away really does take a long, long time. A little longer for knees than hips, unfortunately. Hip replacements also are a little different from knee replacements in that most people, when it's all said and done and they're recovered, do say, my hip feels good as new. I literally, if they only had one that they had a problem with, they'll literally say, I can't even remember which one it was anymore. And we really don't know why, but that is a difference between hip and knee replacements. Hip replacements are the most successful surgery in all of orthopedic surgery, and maybe even in all of surgery, in terms of how often does it do what it's supposed to do. What it's supposed to do is get rid of all of or nearly all of the pain and allow people to function normally or nearly normally. When you judge it based on that, it's about 98 or 99% successful. Knee replacements are more like 95 or 97%. Again, we use the same implants, and this is for knees and hips. And the surgery is definitely different, and it's meant to reduce the trauma, get people moving more quickly, and get them back to normal more quickly, but the surgery is only part of it. There are other changes that are probably just as important. How we control people's pain, not only how well, but what exactly we do to control it. The therapy protocol, you used to be in a cast after knee replacement when they were invented. We'd put people in a cast, have them lay in bed and not move for weeks. And it was a lot harder to overcome not only the surgery, but also the deficit that we caused by putting people in a cast. But people, they just didn't know what we could do and couldn't do with these things. So that's what was done at first. And then how involved the patient is in their recovery is very different from how it was even when I started my training when I got out of medical school 12 years ago. The more involved somebody is in their rehabilitation, the more they know about what to expect and how to be involved and what we expect of them, the better they do and the faster they get better. Instead of saying, okay, now we're going to do this, and then after the surgery, now we're going to do this, it's better to know ahead of time, just like it is with most things. So how involved we get people has changed a lot. And then also, I put this in there just to emphasize that we also know we cause a lot of other problems when we do this. The pain control, and it's specifically narcotic pain medications, and morphine being historically the most common one, causes people to be constipated. And if we're not aware of that and we don't treat it, that can become a bigger problem than the pain from the surgery. That's just one example of a lot of things that we do to intervene that can cause problems. Traditionally, people, again, I'll use hip replacements as an example, came in the hospital a couple days before surgery. They had all their lab work and all their blood tests and all that stuff for the couple days before surgery. Surgery was 3-4 hours long and huge incisions and huge amount of blood loss and big surgery. They were in the hospital for weeks afterwards. They were on crutches, non-weight bearing for months, and it took forever to get better. They were constipated. They had catheters in them. They had sometimes central venous lines in them. They had all kinds of invasive things. I don't do it like that at all anymore. People, the average hip replacement takes me about 30 minutes. People don't have a Foley catheter in. They walk on it the day of surgery. Most people go home the day after surgery. And we're really aware of side effects of medications, minimizing them. We give more than one type of pain medication to minimize how much of any one type someone needs to get, and therefore minimize the side effects. Best way to have a joint replacement, whether it's a hip or a knee, is with what's called regional anesthesia, either a spinal, a nerve block, or some combination of those things, because general anesthesia, we know, causes some side effects, not the least of which is often nausea. You can't concentrate on your recovery, and you can't get up and test out your new hip or knee if you're sick to your stomach to the point where you can't open your eyes. So we are a lot better at treating the whole patient, I think, than we were years ago. Oh, now it's getting stuck, sorry. So this is just kind of some of the things that we do. Femoral catheters, epidural catheters are just different versions of what's, for all intents and purposes, like an intravenous line that goes to or near a spot where there are nerve endings and drips some Novocaine type medication there. So the thing that we use all the time in this hospital is a femoral nerve block. The anesthesia doctor takes a needle, threads a small catheter through it, takes the needle out, and leaves that little plastic tube in place for a day or two after surgery to deaden the feeling in the main nerve in the front of the leg, which makes it hurt a whole lot less, which means we give a whole lot less of those other pain medications that can cause some problems. Ice has been around longer than just about everything and probably works as well as just about everything in controlling pain and swelling and inflammation. PCA stands for patient-controlled analgesia. We do occasionally use that, although we're getting away from it because the main way that it's used is with narcotic medications, and we try to minimize that, and it doesn't work as well as we thought it did when it was real popular in the late 90s. We use combinations of medications, non-steroidal anti-inflammatory medications. This is just a particular version of those. Short and long-acting medications, we try to prevent the pain rather than treat the pain. It's not to say that these things don't hurt. Unfortunately, even though it hurts less than it used to, one of the guys that trained me, I think, put it the best, and he would always say to people who had already had a hip or knee replacement 10 years ago, he'd say, well, it's better than it was. It doesn't hurt as much, but it's still not like getting a haircut, and it isn't. Unfortunately, there still is some discomfort associated with surgery. And every person I've ever had who's had hip surgery, knee surgery, unfortunately says that knee surgery is a little tougher than hip surgery in terms of the discomfort and how hard it is to work on the rehabilitation afterwards. So we do all kinds of things to try to prevent side effects. We do things before, after, and during surgery to try to prevent side effects from medications, side effects from anesthesia, problems that we know we're causing from some of the interventions. Sorry, this is sticking. I should just go from here. So, for hip replacements, even though you probably could get away with telling people to do whatever you want, I still follow hip precautions, and most surgeons do after hip replacement. No matter how we do hip replacement, we have to get into the hip somehow. We open the lining of the hip, and we take the ball out of the socket to be able to do the work or dislocate the hip. If patients get into that funny position that we purposely dislocate the hip during surgery, after surgery, before the stitches down deep are healed and things are solid, they could pop the ball back out of the socket. So some approaches allow for relaxed or no hip precautions. It's not entirely true that there are none. It's just that the funny position that we put folks in during that particular version of a hip replacement, they don't get in, so we don't have to remind them not to. Probably the biggest thing that's allowed us to have less of a problem and less of a risk of dislocation of hip replacement, though, is a change in the size of the ball for the ball and socket that we use. The bigger it is, the harder it is to pop out of the socket, and some improvements in the materials in the last few years have allowed us to use, on average, a larger size. Also, smaller incisions, cutting less out, taking less pieces apart and out makes it a lot more stable and has significantly decreased that risk after hip replacement surgery. We do everything faster. I think you probably gathered that from the comparison I just gave. And that's relative to the norm or the traditional way. It depends on the patient, of course. Everything is patient-specific and tailored to the patient. If we have a perfectly healthy 45-year-old who had a car accident, broke their hip, and went on to need a hip replacement, they're obviously going to get faster than someone who's 85 and has heart disease and lung disease and another joint that's arthritic and a bunch of other problems. But we accelerate it relative to what would have been traditional or the norm for that patient. The whole goal is to get people back to their lives faster and cause less pain and disability and inconvenience and everything else that we know we cause when we do these procedures. I want people to go home as soon as they possibly can. Once they're safe, getting around the house, doing the things that you need to do, getting back and forth to the kitchen, to the bathroom, in and out of bed, people do better, feel better, faster, are more comfortable, and recover quicker if they're in their own familiar surroundings. It's not just that the insurance companies are breathing down our neck telling us to send people home faster. There's actually an advantage to it. We get people to outpatient physical therapy as soon as they're up to it. Often people have visiting physical therapists at first for practical reasons, but there's more that people can do at a physical therapist's office with all the fancy equipment and machines and things that they have. In general, the norm is immediate full weight bearing. Whether it's a hip or a knee, we want people to bend, 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 and walk, walk, walk. CPM stands for continuous passive motion. That's the machine that bends the knee back and forth while people lay in bed. Jury's out on whether or not ultimately that makes a difference. Most studies show that ultimately it doesn't. It may make a slight difference in how much bend somebody gets in the short term. So therefore, we're divided at this hospital. I don't use it and my partners do. It's just a matter of preference. We get rid of the crutch, the cane, the walker, the wheelchair, whatever someone's having to rely on as soon as we can. And that's different for different people. I have some folks that are using nothing in a couple days, and I have other people that use a walker for 6 months. It depends on how much trouble someone was having getting around before some of these surgeries. So after folks go home, they continue their therapy. They keep fully weight bearing. They get rid of those devices. They follow the precautions, at least for the way I do surgery, for 8 to 12 weeks after surgery, about not bending in a certain funny position that we did during surgery. It's pretty easy because most people with an arthritic hip can't do that before surgery, so we just have them continue to not do it for a little while afterwards. Obviously, we check on folks during their hospital stay in terms of monitoring their vital signs and looking for signs of blood loss and things like that. They go home when they can. It's often the day after surgery for hip replacement, often, probably most often, the second day after a knee replacement, but occasionally it's the day of. One of the places I trained along the way, one of the 6 surgeons has done all of his joint replacements for the last, I think, 5 years now as outpatient surgery. So it is possible to even go home the same day. But again, it's tailored to the patient. It depends on how quickly the individual progresses. We have probably the best education experience for patients here that I've seen anywhere along the way. And I've trained at places like Johns Hopkins and Rush University and big places like that. The more somebody knows about what to expect and what's expected of them, the better they do. And we do a really good job of it here because it's a manageable size place. It's big enough that we have the best technology, we have the best trained people, we have the best staff that you can based on kind of the current latest greatest, but it's small enough that people are still individuals rather than one of thousands and thousands of patients. And it's kind of, for me at least, why I like to work here, because it's the right balance of those two things. This is a big deal. It's an invasion into someone's body, and the less that we can make it that, the better. And that's the whole goal of the less invasive or minimally invasive surgery. It has been shown that people get better faster if they feel like we're doing less to them, and not just from the physical, but from the mental perspective. That's important. So these are, again, just some averages. People go home on average a day after a hip replacement, 2 days after a knee replacement. All of the folks here that do joint replacements put patients on blood thinners. The particular one we use here is Coumadin or warfarin, and we do that for a month after surgery. The recommendation from the Academy of Orthopedic Surgeons is that people either be on that or an injectable version of a blood thinner for anywhere from 4 to 6 weeks after surgery to minimize the risk of blood clots. Unfortunately, it's still surgery. That's why it's the last resort after all the non-surgical treatments. That's why someone's a candidate for surgery or not. They don't have to have surgery because of the risks. There are a bunch. Some of them are big risks in terms of how catastrophic and awful they are. Fortunately, those are rare. Some of them are small risks, but happen more often. So, you know, like I said at the beginning, anyone who's a candidate for joint replacement surgery, in my mind, should have some version of the better techniques that we've come up with in the last few years. It depends on the size of the person. That's why people ask me all the time, how big's the incision? Well, if someone's 6'8" and 400 pounds, the incision's bigger for them than someone who's 5 feet tall and 95 pounds. It's smaller than it would have been for them historically, really, is the answer. Depends on the severity of the arthritis. If we have to do a whole lot of work, sometimes we have to make a bigger incision or do more once we're in the incision. And I always tell people I will make as big an incision as we need to put the parts in right. That being said, knock on wood, I've never had to make it bigger or kind of change from the original plan, but I would, because what's most important is how these work in a year and 2 years and 10 years and 20 years. And what influences that the most is how well the parts are put in. So they have to be aligned properly, they have to be sized properly, it has to be done to the standard that we know is the best and what makes them work and makes them last for a long time. Just like you don't want the latest, greatest device, in my opinion, you don't want somebody to compromise how they put it in just to do less invasive or minimally invasive surgery. So there's less trauma, less bleeding, less pain, smaller scar, not as important, but some people talk about that. It's obviously the most noticeable external thing that you see. Shorter hospital stay, basically less invasion of someone's life in terms of time and pain and effort and everything else. It is still evolving. There are a bunch of studies underway. There are a bunch of people that will argue one way is better than the other. I think everybody agrees now, everybody that does joint replacements at least, that a lot of the things we've come up with are useful no matter what, whether you're a big believer in minimally invasive surgery or regular old surgery or maximally invasive surgery. We've changed, things constantly evolve and get better, and I think they have gotten a lot better. There have not been any giant leaps forward in joint replacements. Unfortunately, I don't think there will be until we figure out how to cure arthritis. And that won't be a leap forward in joint replacement. That will probably eliminate the need for it. I think it's coming. Unfortunately, I don't think it's coming real soon. Computer-assisted surgery exists for hip and knee replacements. It's as good as doing it without a computer. So far, none of the studies have shown that it's any better. I think eventually that will change as well. In other fields in medicine, and especially in other subspecialties of surgery, and specifically urology, using robotics and computers has been shown for certain procedures to be an advantage. I think eventually that may be the case with joint replacements, but not quite yet. Any questions?
Are you going to go on
Things are very, very uncommon, but devastating. Some of them are more common. There's about a 1 in a million chance of something terrible going wrong with anesthesia, heart attacks, strokes, something catastrophic. Anesthesia is very, very safe nowadays, but not 100%. We do a lot of things before surgery to make sure it's as safe as possible. We do some routine tests for everybody. We have everybody get a physical, or we do a physical depending on the logistics of it, and we make sure that someone is in as good a shape as they possibly can be before we do an invasive surgery that requires anesthesia. There's about a 1 in 500,000 chance of a fatal blood clot. For some reason, there's a very large risk of blood clots when we do orthopedic surgeries from the waist down, hip surgeries, knee surgeries, pelvis surgeries. They form in the deep veins of the legs and pelvis and can cause pain and swelling in the leg. That's called a deep vein thrombosis, or a DVT. The chances of that are 1 in probably 1,000 or so of people getting a very painful swollen blood clot in the leg. It's 1 in 500,000 that then breaks off, goes to the lungs, and causes what's called a pulmonary embolism, and that can be fatal. That's the reason that we put people on blood thinners. We put pumps on their feet during and after surgery. We have them wear special stockings that help with circulation in the deep veins for a month after surgery. All of those things have been shown to drastically decrease the risk, but unfortunately they don't make it zero. There's a 1 in several thousand chance of damage to a nerve, an artery, a bone, a tendon, a ligament, something around where we're working. If the general surgeon's taking out someone's appendix, they can hurt the intestines and the other intra-abdominal organs that are around it. If we're working on a knee or a hip, occasionally things where we're working get hurt. Most often, believe it or not, it's not an oops, we slipped direct injury. That pretty much, I don't want to say never, but that is extremely rare. It's most often a stretch or movement injury. We're dislocating a hip, we're putting it in a position that it either hasn't been in a long time or has never been in, and most often those injuries occur with a stretch. Same with the knee. It's very rarely a direct injury to a bone or a ligament or an artery. It's moving a knee, bending it further than it's bent in 10 years, and a bone breaks or a ligament tears or an artery kinks. So those things can happen during surgery. Fortunately, they're rare. There's bleeding no matter what with surgery. There's not much of a risk of needing a blood transfusion after a first time around or a primary joint replacement. For redos, that's a completely different thing because sometimes that's a lot bigger deal. But the people who are at largest risk for needing a blood transfusion are the patients who have a low blood count before surgery. There are some risks with blood transfusions. The biggest one is an allergic reaction. Smaller risks, but usually a bigger deal, are some sort of infectious disease like HIV. extremely, extremely rare to need a blood transfusion, and even far more rare to have a problem nowadays with how things are tested. Kind of moving along the spectrum of what can go wrong, these are mechanical, metal, and plastic parts. They can wear out. Most often they last 15, 20, 25 years, but there are the occasional folks who wear them out in a year or two, or have a part that comes loose from the bone in a short period of time. No matter what parts we're putting in, we're relying on either cementing them in place with a special cement, and that's what we do most often with knee replacements, or putting them in tightly with friction and then relying on the bone actually healing to the part. And you can look at some of these parts, and that's why we brought them. This is a hip replacement stem, or the anchor. It's real rough on this part that looks different and is lighter colored at the top. It goes in very tightly with friction at first, and that's how it stays in place at first. We then take advantage of the fact that the bone is alive and will heal, and fool the body into thinking that this is a fracture, and the bone actually heals to it. There's a chance that that doesn't happen. The parts are so good now that that's probably one of the most rare things that can happen, but it used to be one of the most common things that happened before we figured out how to make these as good as they are nowadays. The biggest risk overall, in terms of percentage risk though, is an infection. If you take all patients, hip and knee replacements, and all categories of patients, it's about 1 in 100 to 1 in 200 risk of an infection. Yes?
What if you're diabetic?
The question was, what if you're diabetic? All the risks are typically higher, is the answer. The risk of an infection, not the risk of a blood clot, the risk of skin and healing problems. The but to that statement, though, is the better controlled someone's blood sugar is, the less the risk. If someone has a normal hemoglobin A1C and very good blood sugar control, they're actually in the normal risk category. Which leads me to my next point, thank you, that there are categories of risk for infection. If someone is having a redo joint replacement, has poorly controlled diabetes, has an immune system problem, and has an inflammatory arthritis, they're about a 6 or 8% risk of getting an infection. If someone has none of those problems and they're having a first-time joint replacement, they're far less than the 1%. Yes?
The rates of infection that you're talking about, is that based strictly on the patient's physical condition, or does it have something to do with the hospital's, how they test out with infections?
So the question was, do infection rates have to do with the patient's condition or the hospital? The answer is yes. You can risk stratify or categorize someone's infection risk no matter what hospital they're having surgery in. But then from hospital to hospital, infection rates are definitely different. Not hugely different, but there are differences. Ours is actually historically always at or below the national average, and that's what we shoot for, is to be below the national average. When we're below it, it's not like we're 0 and they're 1%. It's fractions of a percent smaller. Also, it's more important to look at our infection rate, at least here, over several years at a time, because we don't do 5,000 joint replacements at a time. If we have one infection, that rate that year is a lot higher. But historically, we are right where we need to be at this hospital. Actually, teaching hospitals have a higher rate of infection. Bigger hospitals have a little bit higher rate of infection, probably because they have sicker patients. So when you risk stratify people, you can then say, well, they're a higher than average risk, they're a lower than average risk, they're an average risk. Tertiary medical centers, big medical centers like Johns Hopkins and places like that have much higher infection rates, but it's probably at least mostly due to the fact that they have the sicker patients who are higher risk.
Also, by discharging a patient like a day or 2 days after surgery, does that cut down on the chance of infection, or?
So the question was, does discharging a patient quickly after surgery cut down the risk of infection? Unfortunately, no, but the types of infections that people get are different in my experience, and there's some studies starting to show that. So hospital-acquired infections in general are different than infections that people get that are called community-acquired infections when they're not in the hospital. The infections we're talking about, the overwhelming majority of the time, are bacterial infections. Bacteria, unfortunately, when we have surgery, unfortunately, live everywhere. There are millions per square inch on our skin. It's the job of the surgical preps that we do, and we actually go to the extreme of having people use surgical scrubs at home before surgery. We do it several times at the hospital. We do it and prep and do the things you see on TV where they put sterile drapes and everyone's wearing masks and all that stuff. That gets rid of a lot of the bacteria on the skin. The antibiotics we give someone before surgery and for a little while afterwards gets rid of a lot of it. Doing surgery efficiently and quickly actually minimizes the risk of bacteria getting in because incisions are not open for 2 and 3 hours. They're far less time. So there's some correlation with how quickly surgery is done with infection risk. Despite all of those things, with millions of bacteria per square inch, there's still bacteria that get into the incision 100% of the time. It's the job of the antibiotics we give everybody for around surgery and your immune system to get rid of the rest. And that's why different folks have different degrees of risk because they have different immune systems. Diabetics, people with immune system problems, things like that. When infections happen after surgery, it depends on the surgery how big of a deal it is. If someone's having their gallbladder out and they get an infection after surgery, curing it may take giving them some antibiotics and watching it get better. Unfortunately, when we're implanting artificial parts, whether it's joint replacement parts, heart valve replacements, pacemakers, anything that's metal, plastic, or artificial, when bacteria stick to these things, we could give you all the antibiotics in the world and we can't cure the infection. It's not a living thing. It doesn't have a blood supply to it. There's some particular things that bacteria do to kind of set up shop, so to speak, to stick to metal and plastic and artificial implants. And once they've done that, the cure becomes more drastic than antibiotics. It's often taking out the parts, leaving them out temporarily, and putting new ones back in. The rate of cure for infections after joint replacements is extremely high. It's in the high 90s in terms of percentage. It's just that the cure is a lot more drastic than if someone has an infection after an e-scope or an infection after an appendectomy or something like that. So it's a really big deal. We're obsessive compulsive about it. We are continually making progress at it here and nationally and internationally, but we can't seem to get that rate a whole lot below 1%. When they first were doing hip replacements, it was about 20%. And the only people that were candidates for surgery were literally people who were, the choice was walk or not walk, and they weren't walking, and that's why people had surgery, because we just didn't know what these things did, and there was an extremely high rate of complications. We've made it a lot better. It's still not perfect. Yes?
Can you comment on rehab and when it's recommended and what's the usual length of stay there?
Inpatient rehab or out? Okay. So the question was, can you comment on rehab and when that's recommended and what's the usual length of stay? Most people go to rehab when they meet certain criteria that are set by the insurance companies more than anything else now. They, I mentioned people go home when they're safe and able to go home, when they can walk an appropriate distance, when they can get on and off the toilet, when they can get in and out of bed and do all those things safely. Basically, someone goes to rehab when they can't do those things within several days after surgery. The length of stay is anywhere from a few more days to weeks. Occasionally, a month or so. Really the only people I can think of in the last 5 years who have gone to rehab for a month or so are people who were extremely, extremely debilitated before surgery, literally not walking before surgery. If we just magically made their hip or their knee better, they'd have to go to rehab just to recover from their disability prior to surgery, not just to recover from the surgery.
It's not a standard.
It's not a standard at all to go to rehab. It used to be. My grandmother had her knee replaced in the early 90s, and the plan was before surgery she would go to rehab and she'd go for 2 weeks. Some of that was differences in the surgeries and the protocol. Some of it was hospital facilities and surgeons owning rehab centers and making more money doing that. Good, bad, or otherwise, that's changed a bunch. I think it's for the better. We have those resources when we need them. Most of the time we don't. My whole goal in everything that I do as far as elective surgeries, and even emergency surgeries with broken bones and things, is to get people back to their lives as quickly as we can. Yes?
Was it, in your answer to this question, did you speak of preoperative rehab? Can you say more about that?
So the question was preoperative rehab, or some people refer to it as prehab. It is a great thing, in my opinion, but unfortunately not usually practical. The stronger somebody is, and I'll use knee replacements as an example, the stronger their thigh muscles are, the better their knees moving, the overall better their health is, and their fitness, their physical fitness, the faster they get better afterwards. But going to do physical therapy or working out or doing some of those things before surgery is not often practical because it hurts. And unfortunately, more often than not, because of insurance limitations. So most people's insurance policies limit the number of visits they have a year to a physical therapist. And it's far more important to save those visits for after surgery than to use them up before. This time of year, I actually am able to have more folks go to physical therapy ahead of time because they use up those visits and then the year resets and then we use them afterwards. So for people who either aren't limited by their insurance, which is unfortunately very few, or are inclined to do those things on their own or just pay for visits with the therapist, we use that and it's helpful. It's not all the time though. The best exercises before hip or knee replacement surgery tend to be things that are not fully weight bearing on the hip or the knee. So riding a stationary bicycle is great exercise for the muscles of your lower extremities, but it's not full weight bearing on your hip or your knee. Swimming, walking in a swimming pool is probably just as good or maybe even better, but a little less practical because especially around here it's hard to find a swimming pool to use. Kind of the next step down in things that are good, elliptical machines, Stairmaster machines, things that are not running or pounding or walking are usually a little more manageable for folks, even with hip and knee arthritis. I unfortunately have an arthritic hip myself, and I find I can't run anymore, but I can ride a bike all day long. So it's a matter of figuring out what you're able to do, and the more you're able to do ahead of time, the better, for sure. And then I think, yes?
For a partial knee replacement, typically, what kind of anesthesia is used?
So the question was for a partial knee replacement, what type of anesthesia? I recommend spinal anesthesia for all joint replacements. Most people don't take me up on that, but it's been shown, especially for hips, there's less bleeding during surgery in studies where the same surgeon has done the exact same surgery the exact same way and looked at patients with spinal anesthesia versus general anesthesia. There's less bleeding, less nausea, less risk of complications from anesthesia. That's also true with knee replacements, although the bleeding is not as much of an issue because typically we use a tourniquet during at least part of the surgery on the leg and there's no bleeding for that part.
What about if you've had disc surgery? Does that...
So even if you've had disc surgery, even spine fusion surgery, most of the time the anesthesia doctors are still able to do spinal anesthesia. So people's main reason for not choosing that is not wanting to be aware of what's going on during surgery. And even though they give you some medications that typically cause amnesia or cause people to sleep through surgery or forget what goes on during surgery, they give the same medication typically that they give for colonoscopies, and lots of folks have had that done, and they know that those medications make you not really care what's going on. But people do occasionally hear and remember parts of what they hear, and we do these surgeries. It's kind of like doing sterile carpentry, so there are some tools involved that sometimes people hear and remember. I've never, ever had any patient tell me ever that it was a big deal. Even people who are very, very concerned about that. A couple people that I can remember who couldn't have general anesthesia, even though they wanted it, everybody kind of says afterwards, oh yeah, I heard it, but it didn't matter, I didn't care, and I didn't feel a thing. So it really is the best way to do it. I wish that it was that we did spinal anesthesia every single time. That being said, it's not mandatory, and if people just want general anesthesia and the anesthesia doctor thinks that that's a good alternative and a safe alternative for that patient, that works just fine too.
Just for a comment on that, I've had 2 hernia surgeries done here.
Yes.
George Barkel was the anesthesiologist. I requested him on the second one. They were both spinals. I had a ball. I laid there and talked to nurses. I have tattoos with names of all the dogs that I've owned in my arms. We were having a conversation as the surgeon's working.
Yep.
And it was not bad at all. I would much prefer that than to be intubated. No, thank you.
Yep, and lots of people feel that way. Occasionally people don't want the medication that makes you sleepy, and they'll talk to us during the surgery, and that's just fine too. You don't see what's going on, and you definitely don't feel it, so it works just fine. Yes?
So, what percentage of people have a general versus a regional?
What percentage of people have a general versus a regional at this hospital? 'Almost 100% of knee replacements have a femoral nerve block, so technically that's a regional. For my practice, it's probably slightly better than 50-50 now, people having a spinal. When I first got here, it was almost nobody, and I'm slowly but surely changing the minds of a lot of the folks involved, including patients.
Do you like spinals better than epidurals?
I like epidurals a whole lot. We don't have the capacity to do them here and monitor patients on the floor. So we don't routinely do epidurals for joint replacement surgery here. Actually, my favorite is a combination spinal epidural where they do both in the same procedure. And where I did my fellowship, that's what we did. They would do the spinal anesthetic for the surgery, leave the epidural catheter in afterwards, and actually that's how they did the outpatient surgeries, was they would leave that in for about 6 hours afterwards, and people would get it out just before they left. I'm working on it, but it is logistically a bit of a nightmare to create the proper support to do that here. And unfortunately, with things out of my control and out of the hospital's control, limiting spending and technology and everything else, I don't know that we're going to be able to do that routinely. I do use epidurals on case-by-case basis, and there are sometimes cases where that is real important and we do it, but I don't routinely because of logistics. Yes?
I have a question about the non-steroid anti-inflammatory. I went to the pharmacy the other day and got my bottle of ibuprofen, without which I can't live. And I had a long lecture from the pharmacist. Oh, you can't take these, you could have internal bleeding, you need to talk to your doctor and so on. I haven't been really getting much help from my doctor. I don't know what to take. Tylenol doesn't work. And I don't know how much ibuprofen I can take. I am also using it as a blood thinner at the same time. So what do I do?
So the question was, non-steroidal anti-inflammatories, and specifically ibuprofen, what are the risks and how much can you take? All of the non-steroidal anti-inflammatory medications have 2 major risks of side effects that we worry about the most. There are a whole list of side effects for every medication, but the 2 things we worry about the most are stomach upset, and ultimately stomach upset to the point where it can cause gastric ulcers, and then worsening of blood pressure, or high blood pressure. So people who have high blood pressure need to be monitored real closely if they're taking non-steroidal anti-inflammatory medications on a regular basis or for a longer period of time, because it can affect the high blood pressure and worsen it. And then everybody who takes those medications needs to be aware of stomach upset. If they start to have it, they need to let their doctor know and or just stop the medication. Sometimes it's a matter of modifying doses or regimens. Sometimes it's a matter of putting somebody on stomach protectant type of medication that's meant to prevent ulcers. Sometimes we have to stop it. In terms of how much ibuprofen to take, the maximum dose of that medication is 800 milligrams 4 times a day. I wouldn't recommend taking that much off the bat. With any medication, ibuprofen or otherwise, you should take the minimum amount. Now, this doesn't apply to heart medications and blood pressure medications and stuff, but pain medications or as needed medications like that, you should take the minimum amount that's effective. Personally, my philosophy is that those medications are most effective if taken regularly, but you want to minimize the risk of side effects. So what I usually tell folks to do is arthritis tends to come and go and wax and wane, and anybody who's had symptoms of it, I'm not telling you anything you already don't know. You'll have, it's not usually good days and bad days, it's good weeks and bad weeks, or good months and bad months. And it is affected by weather. That's not an old wives' tale. It's affected by activity. It's worse in the morning. So when you have a flare, my thought and what I've found to be really effective is to take it on a regular basis for a while. If you know your usual flare is a week or 10 days, take it for a week or 10 days, whether it's a good day or a bad day, and that usually knocks it down better and faster. And then kind of taper off and either use less of it or don't use it. That way you're giving your stomach, in particular, a break and minimizing the risk of stomach upset and ulcers. Yes?
I had a complete knee replacement 14 years ago, and that's been great. It's still very good, but I had one done 9 years ago. And within 6 months, I had scar tissue and bone spurs again. And like you say, I had, like last week, a couple of days, I could hardly walk on it, but the last couple of days, it hasn't bothered me. If I came to you, what would you recommend? What do you do for something like that?
So the question was, what do you do for a knee replacement that isn't quite perfect? A big part of what I do, being the subspecialist in hip and knee replacements, I did a fellowship, which is being a glutton for punishment. Most of us in orthopedics do extra training beyond even our residency. So mine was specifically in hip and knee replacements. We're all trained in doing that, so you don't have to be fellowship trained to do it. What that means is that what falls to me to treat a lot of times is problems with hip and knee replacements. So it's something I see every day. It's my job to figure out, is it not a great knee replacement because there's something wrong with it, or is it just unfortunately one of those 6 or 8% that's just not quite a perfect knee replacement, or not quite as good as the other one in your case? Yeah. So there may be something wrong with it. It may just be a difference from one leg to the other. I can't give you a better answer than that, unfortunately, without looking into it. There are a whole...
One of yours over there, and he said, well, it would be almost, the procedure would be almost as much as a knee replacement to go in there and...
Take out scar tissue.
Yeah,
So the rate of success at redoing joint replacements, knee replacements, or hip replacements is extremely high if we know what's wrong. So it sounds a little bit counterintuitive, but I prefer, when I see a knee replacement or hip replacement that's not working right or doesn't feel right, that I find something drastically wrong with it, because I know I can fix that. If you can't find anything wrong, you shouldn't redo it just for the sake of redoing it, because the rate of success is really low. So in other words, there are some of these things, more so knees than hips, that just aren't quite as good as average, and we don't know why. One of the biggest things we see with knee replacements is the best predictor of how much range of motion someone has after surgery is how much they have before. I saw a patient in the office a couple days ago who came in for another opinion after a knee replacement that only bends 90 degrees. But when I examined that patient's other leg, it only bends 90 degrees. And I asked that patient, how much did the knee that was replaced bend? She said, oh, less than the other one. So it's actually better than it was before surgery. It's just not normal. And I think that's more a matter of expectations than anything. That person should have heard from someone along the way, and maybe they did, maybe they didn't. I really don't know. You can expect a knee that won't hurt as much, but probably will only bend as much. Well, so hurting a lot can be any number of things, and that we certainly can look into.
Yeah, well, you have records on me over there, so.
Yep. Yes?
If you have determined that both of the knees need to be fixed, what is your preference on doing them one at a time or two at the same time?
So 2 at once or 1 at a time? I love that question. Thank you very much. It happens every time. My preference is 1 at a time for a whole bunch of reasons. First and foremost, there are some absolute reasons to only do 1 at a time. People over a certain age, and there's some debate over that age depending on the study you believe, but people over a certain age have a higher risk of death and other complications from surgery if you do 2 at once. I simply won't do 2 at once for those people. Some people will. There are already enough risks with this surgery. I tell folks I'm willing to take the risks with you, but if I know I can eliminate risks by doing surgeries 1 at a time, then it doesn't make sense to me to take that risk. So then, assuming someone's not in the absolute no category, I prefer 1 at a time because it's really hard on someone. Everybody gets a little bit down after this surgery and discouraged, no matter how prepared we think they are, if they haven't had it before. So the person who's already had one knows, and they're the exception to this, but everybody gets, and the best way I can explain it, I explain it to people, you will reach a point sometime after surgery, either a day or a week or 6 weeks, where you say, I can't believe I let Dr. Lighthart do a knee replacement on me. This is terrible. This is worse than I thought. And then sometime after that, they reach the light at the end of the tunnel point and the turning point where they say, geez, you know, I've really worked hard. I'm recovering from the surgery. I feel better, and I can already see where this is going to be better or already is better than it was when I started. But no matter how prepared we think we have someone or how prepared someone thinks they are, they have at least a little bit of that moment. Some people really have that to a large degree and get very discouraged. It's far more common after 2 at once for it to be really tough for someone physically and mentally. That being said, I think that sometimes it makes sense to do 2 at once. Occasionally people have such a deformity or their knees are stuck so bent that if we fixed one, the other one literally wouldn't touch the floor, and it makes sense to do 2 at once, maybe even if it's real extreme for the person who's in that high risk category, because if you just can't walk after surgery, we're not really helping. A lot of folks, I do 2 at once for other reasons. You know, you have to consider everything. Their person's medical problems, their knee or hip or whatever we're working on, but also the rest of their life. If it's someone who works 2 jobs and has a mortgage and a car payment and everything else that we all have, and they literally say, listen, I have this amount of time off of work, and if I do more than that, I'm going to lose my job and lose my house and everything else, then it makes sense to do 2 at once for those people and just kind of put up with the fact that it's a little harder in the short term, but over with sooner in the long run. So like a lot of things, it's individual. My preference is 1 at a time with some exceptions, I guess, is the short answer to that question. Yes?
If someone's been told that they've lost most of the cartilage in their knees, both knees, does that then cause hip problems? And then can that hip problem, or I guess you really would know, can that hip problem be helped by the knee replacements?
So I think the summary way to say that is, does one joint being arthritic and worn out affect the next one? The answer is absolutely yes. If you have a worn out hip and it's stiff and doesn't move, almost 100% of people get some pain in the back and the knee because those joints above and below have to do more. Same with your knee, same with your foot, same with your ankle. If one joint is not moving or working normally, the joint near it usually sustains some more burden and can be affected. The kind of follow-up or addition to that is if someone has a very arthritic hip, a very arthritic knee, a very arthritic ankle, and we know that we're going to intervene on all of those, we kind of start from the top up because we have to line somebody up. So we fix the hip first, then the knee, then the ankle. Because if we do it the other way around, we may be lining up an ankle to a knee or a hip that's not the right angle or shape. But one definitely can affect the other. If someone has hip arthritis and knee arthritis, but the knee arthritis is worse, often we fix the knee first. And yes, it often does make the hip feel better because it kind of takes some of the burden off of the hip, so to speak. Same with if someone has two arthritic hips or two arthritic knees, and one is really bad and the other one's sort of bad. We address the really bad one, and often the sort of bad one feels a lot better because it doesn't have to do as much. Yes?
Can you, in doing hip replacement, can you actually lengthen the leg involved?
Very good question. That's one of the list of, there are more complications than I listed. I just hit on the major ones, but one of the risks of a hip replacement is you actually can lengthen the leg involved. It used to be far more of a risk than it is nowadays. The ball and socket, this is the model of ball and socket, is literally not held in place with anything. It doesn't lock into place or snap into place. We rely on the muscles and the tendons and the ligaments and the connective tissues of the body to hold that in place. There's one big strong muscle in particular, the muscle that lifts your leg out to the side, that holds your hip in place. When we put these in, they go in the bone and they can go up or down to a varying degree, depending on the size and the shape that we put in. We want the hip to be tight enough to stay in place and not be a big risk to pop out of place. Years ago, before we had as many sizes and shapes of these implants, you often were faced with a choice between making the hip tight enough and making it the same length. And always the right choice is making it longer but tight enough, because it's a bigger problem to have it pop out of the socket than it is to have a slight difference in the length or even a large difference. That being said, the parts are so good now and we can match the size and shape to the patient so well that having a noticeable difference in length is far more unusual. Not unheard of, but far more unusual than it used to be.
Now, if you start out having one leg shorter than the other, can you adjust to that?
If you start out with one shorter than the other, you can adjust to some degree. You can make it longer, you cannot make it shorter. Often the biggest thing that I deal with is someone has had one joint replaced and they've been put back to, and this is hips more so, far more so than knees. They've had one hip replaced and it's back to where it should have been, and the other one is worn down and shorter, and they have a noticeable difference. We want to put it back to where it should have been, not where the other one is if the other one is diseased or affected by arthritis. And there's a lot of issues involved with leg length. There's the actual difference, but more importantly, there's the perceived difference. Lots and lots of people have problems with their spine, either scoliosis or arthritis and scoliosis, and their pelvis tilts, and that's the most common cause of an apparent difference in leg length. If we actually measure the bones, they're the same length, but someone's pelvis is so tilted that one, it doesn't touch the floor and the other one does. That's a harder thing to deal with because we can affect the length of the legs, but we can't really fix the curve of the spine by doing anything with the hip, that is. Yes?
Hip surgery, both hips at the same time, is that the same as the knee surgery, or?
So bilateral simultaneous hip replacements, something that comes up for me every other year or so. It's, we can't use a tourniquet during hip surgery. The risk of a blood transfusion is much higher if you do two at once. It's also really hard to follow hip precautions on both sides at the same time. So most of the time it's more surgery than I would recommend at once for somebody. That being said, again, for the patient who has a particular problem, hip flexion contracture is one, which simply means the hip is stuck and doesn't go out straight. someone has that on both sides, it's kind of like the knees that are stuck. If you can't get both feet to the floor, you have to do two at once. So that happens for me about every other year or so. But in terms of electively kind of wanting to just get it over with, two hips at once often does not make sense for folks because it's not as practical to do the rehab afterwards. Yes?
The person is living alone, they have hip surgery and they go home the next day. Are they able to take care of themselves or do they have to have somebody come in and be with them?
So if someone lives alone, can they go home the day after hip surgery? Again, it depends completely on the patient. Most people can. Between friends and family and visiting nurses and visiting physical therapists and all kinds of resources, we generally can get people the help that they need, which often is a little, sometimes is a lot. It just really depends on the person. But I have lots of patients that do live alone and go home the next day. The biggest obstacle tends to be stairs. You can do stairs. You do them before you leave the hospital. That's usually that last hurdle in the set of criteria to go home. But what I tell everybody is you're not doing them fast or easily. You kind of should minimize the number of times you have to do them. So if bedroom's upstairs, everything else is downstairs, people typically come down in the morning, stay downstairs all day, go back up at night. And that's very reasonable to be able to do within a couple days after hip and knee replacement surgery.
Is that the same for me?
Yes. Yes.
What, you made reference to hip restrictions, but what specifically are you restricted from doing?
So the question is, what are the hip precautions or hip restrictions? I purposely have kind of avoided that because it depends on how you do the hip replacement. For me, the most common way that I do hip replacement is a mini posterior approach. So the incision is sort of at the back edge of the bony part of your hip that you feel on the side. But more importantly, what we do underneath is we open the lining of the hip joint in the back for the way that I do it most often. Again, there's some variation determined by the patient and what I think is best for them. But the way we then take the hip out of the socket is to bend it way up and bend it way across. Again, I have arthritic hips, so I can't really do it, but it goes way, way up and way across. So that's the position that I have people avoid. Most people don't do that all day long except for one situation. When people get up out of a chair, sometimes they do that. Most people with an arthritic hip can't do that or don't because it hurts. But if you lean way forward to get out of a chair and then kind of even go further than that to the point where you're almost going to fall on your face, that's bending too far. Probably most of the time that would not result in a hip dislocating, but I'm not a probably type of person. I'm a better safe than sorry type of person, so I limit everybody. The main thing you do is you just get up with your leg or your foot kind of either under you or just slightly in front of you. And that's the main crux of posterior hip precautions, or the main precautions I have people follow. Technically, you're not supposed to bend past 90 degrees, cross the hip way across the midline, and internally rotate the hip, or basically lift the leg to the side. Practically, you don't want to do all those three things at once, because that's what we do during surgery. And it's to an extreme, but we don't want to get anywhere near that extreme. For other versions of hip replacements where the ball is taken out of the socket in the front, it's kind of the opposite. We don't want people to extend the hip and turn it out. And the common scenario or the common time when you do that is getting out of a bed. So when you get out of bed and drop your leg off the side, that's when people who have that version of a hip replacement are at risk for popping the ball out of the socket.
How about things like driving?
So the question is, how about driving? When can you drive after a joint replacement? Depends on which side we're working on. With the right side or with the left, if you have a clutch pedal, you have to be able to work the pedals safely and not hesitate. Takes anywhere from days to 4 weeks, depending on the person, depending on what we're doing, depending on how much work we have to do. That is a decision that only the patient can make. I tell people to sit in the car with the car not running and work the pedals and be honest with yourself. If you're slowing down or if it's hurting, you're not ready yet. The other main criteria, and these usually go hand in hand, is If you're taking the narcotic pain medication that we prescribe after surgery that says don't operate heavy machinery or drive on it, you're not ready to drive yet. Those two things usually go together. By the time you're having little enough pain that you're only taking the pain medication either at night or after physical therapy or something like that, it's usually not hurting enough to inhibit you working the pedals.
If you are driving, typically getting in and out of the car, is that?
So getting in and out of the car, unless you drive a Ferrari or a Corvette, or something real low, which lots of people do, it's usually not as much of an issue. You just get in the car normally. If you have something that's really low, we kind of work with you and teach you how to back into the car instead of kind of climb in sideways. You do have to follow those rules getting in and out of a car. But honestly, the most common scenario, the time when I've seen most people dislocate, and this is fortunately, knock on fake wood, I've had one person dislocate in 5 years since I've been here after a first time around hip replacement. But in training, I've seen plenty of people dislocate joint replacements before we had some of these better techniques and the better parts and stuff like that. It most often happens getting off the toilet, because that's the lowest place that someone sits on a regular basis and usually doesn't have handles or something to grab on. So we often, I don't want to say always, do we always? We always have someone get either an elevated toilet seat or a commode that has handles for that exact reason. And it's just more comfortable to, especially if you're tall, if you're sitting on the typical, especially older fashioned toilets, they're so low that it's just not as comfortable after a recently replaced hip or knee. Yes? Do I do the anterior approach for hip replacement? Not routinely. I've done it. I've done every approach to the hip.
Because I've seen it on your profile, that's why.
Yep. I am trained in that. I'm proficient at it. I choose not to do it because without getting into a lot of specifics, I don't think it's as good as the way that I do it routinely. If someone had a particular problem, I would do that. So if someone had a very large hip flexion and contracture and a specific deformity, I think that that's the best approach because you're better able to address that. But for the 99.9% of people who have a more typical pattern of arthritis, I don't like that approach as much. There is no perfect approach to the hip. They're all some version of an incision and opening the lining of the hip and dislocating the ball and socket. They all have advantages and disadvantages. If there was one best way, everyone would do it that way. There are about 4 really common ways that it's done nationally and internationally, and there's probably more like 40 variations on each of those. So anterior approach to the hip has really been advertised and pushed lately as the newest, latest, greatest. It's actually been around for about 100 years, that approach to a hip, well before hip replacements. We've just figured out some ways to do a hip replacement with that particular approach to the hip. The disadvantages of it, and the reason that I don't think it's as good as the way I do it, it takes about twice as long. There's a little more bleeding as a result on average, and I think that that's probably related to just the length of surgery, and it requires putting a hook on the thigh bone and pulling it up mechanically, and there's more of a risk of breaking bones that way. That being said, I think it's a really good approach to hip replacements, and I think it has a lot of advantages over some of the other ones. I think probably, in my opinion, the 2 best are anterior or anterolateral hip replacements, and there's a bunch of variations on the theme, and then the mini posterior like I do.
I've had the anterior lateral one.
Yep.
So that's
I think that if your surgeon's good at it, and if you have no particular reason for one versus the other, they're all just as good.
How about this large skin nerve that they talk about that could be a major risk?
The lateral femoral cutaneous nerve, when we operate on the front of the hip, I do a lot of hip arthroscopy, and even though it's tiny incisions, often that nerve will be stretched or cut. Mine was when I had my hip arthroscopy, and I have a numb spot on my thigh. That is one of the disadvantages of an anterior or anterolateral approach, is that can and often does happen. It's of no functional consequence because it doesn't control motor function at all. It's a little annoying at first, and eventually I actually can barely find mine now. but at first it was really noticeable. Yes?
I have a knee problem. I've had 2 arthroscopic procedures for a torn meniscus, and my knee is a mess again. I read about a stem cell approach, stem cell therapy. You don't look like you.
So stem cells for arthritis, I think, are probably going to be involved in how we cure arthritis eventually. The place I did my residency now is a big stem cell research lab. There's tremendous promise in being able to turn back on that healing mechanism for cartilage, or figure out the genes and turn back on the genes for healing, and I think it probably will involve stem cells. The current treatments that are being offered are simply injecting stem cells into arthritic joints, and it hasn't been shown to do anything. There's also platelet-rich plasma, or PRP injections, which actually are far more common. Depending on what you read, that may be what they were talking about. The idea there is we take someone's blood, draw their blood, put it in a centrifuge and separate the parts of blood. We take the part that has the platelets or the clotting factors in it and inject that back into a spot that's damaged. We know that a lot of the chemical signals that cause healing stick to or in and around the layer of platelets in your blood. So we basically are giving a whole bunch of concentrated healing factors in a spot where there's damage. It's shown tremendous promise and actually really good effects in tendinitis, bursitis, and lots of things that have potential to heal. Unfortunately, arthritis doesn't have any potential to heal, so it hasn't been shown to have any effect for arthritis. It's been tried and is being tried a lot, but the difference is that particular tissue, that cartilage surface tissue, doesn't have healing potential. Tendons do. They heal really slowly, and I think there's a big advantage to ramping up, so to speak, that healing and speeding it up, and I think those injections do that. Yes?
Physical therapy, what do they do and how long does it?
So what do they do for physical therapy and how long? They do all kinds of things, and it depends on the patient, the length of time. It can be anything from as simple as in the hospital making sure that people have their balance and can use a crutch or crutches or a cane, and teaching them the hip precautions and not doing anything else for hip replacement, and as complicated as therapy 4 days a week, working on passive and active movement of the knee, exercise machines, bicycles, stretching, massage, heat packs, cold packs, ultrasound, all kinds of stuff. That's the kind of the opposite extreme for someone, for example, who has a real stiff knee, and we're working really hard to get as good a range of motion as possible. In general, most people with a hip replacement need a little help with balance. They need a little help with strength, and they probably get a little bit better faster with therapy, although in countries where they don't have the resources or the healthcare resources or dollars, they've done some studies to show that you don't have to do anything after a hip replacement. If you just let someone go and leave them to their own, eventually they get just as good. Knee replacements, on the other hand, you have to get the bend back. It's a race between forming the scar tissue in the knee and getting the bend back. It would be more comfortable if we just said, lay around, don't do anything, keep your leg out straight, and don't move it, because it wouldn't hurt as much because you wouldn't be moving a knee that was just cut open and replaced. But it would get so stiff it would never move again. When you're done, it would probably move about that much. So it's a bend it as far as you can, as fast as you can race. Most people win that race and get the bend before the scar tissue solidifies and it forms stretched out. So there's a lot more involved with therapy from a knee. It's all stuff aimed at getting the bend, mobilizing scar tissue with pushing, literally pushing on it and working it and massaging it, passively pushing the knee, so people pushing the knee, machines pushing the knee, patient pushing the knee, and then lots of stuff to work on strength kind of comes later. Exercise machines, walking, treadmills, bicycles, all those things come into play. Yes.
When it comes time for you to replace your hip, who are you gonna have?
When it comes time for me to replace my hip, who am I going to have? I'll tell you, I would have my partner here who does hip replacements do it, accept that. For a real specific reason, I don't think it's a good idea for a surgeon to have surgery at his own hospital. I want to be routine. I want to be anonymous. I want to be like every other patient because we have protocols for surgeries that we do over and over and over and over. We do joint replacements over and over and over. Everybody gets stuck with the same protocol. Unfortunately, some of the protocol is not as friendly for patients. We wake you up in the middle of the night to check your blood pressure to make sure you're not having low blood pressure. We stick you with a needle the morning after surgery to make sure your blood count's not low. There have been lots and lots of examples of surgeons in particular, but people in healthcare who work at hospitals not being plugged into that routine protocol and problems occurring. So the checking your blood pressure example. We won't wake Dr. Lighthart up because he works here and we know him and we don't want to check. Things can spiral and go wrong as a result of that. I am very torn in answering that question because I obviously think we do a great job here. I obviously think my partner does a great job, or I wouldn't work here and I wouldn't be partners with him. But I need to be just another number.
I didn't mean to put you on.
Yeah, it's a good question, and I don't mind answering it because I wouldn't use myself as an example. And
I asked one of the surgeons this, and they said, like, Mass General or,
yeah.
you know.
Oh, so
Rutland.
basically, the second part of that question is where would I recommend having surgery? Other than here, anywhere where somebody does it a lot. You want someone that does mostly that surgery, and you want it done at a place where they do a lot of it. Now, there's definitely an advantage to not, in my opinion, going to a teaching institution because you don't have people in training working on you. You're not as much of a kind of a number. That being said, you have every right, if you want, to tell someone at a teaching institution, Mass General is a good example, I only want to be worked on by the attending doctor. Other people can assist, but they cannot do the surgery. And they are obligated ethically and legally to.
They have to do that.
Yes.
I don't think people know that they can do that.
Yeah, I don't think people know they can do that.
Well, and typically, the point is really stretched a lot.
It is stretched a lot, yes. Everywhere where I've trained that's been big like that, I trained, like I said, at Johns Hopkins, at Rush University, University of Maryland. I saw people do that at every place, and at least in my experience, every single time that was honored. I'm sure it's not universal because nothing ever is, but every time I've ever seen a patient make that request, and I've been the person in training, the surgeon said, okay, you're going to be the assistant, and you're not going to do anything else because that's what this patient wants, and that's what we're going to do. And no matter where you have surgery, we need an assistant. Here, my assistant is a physician's assistant most of the time. Sometimes it's another one of my partners. Sometimes it's another physician. But we need an assistant no matter what.
You do the main.
But nobody else does the surgery here routinely because nobody else can. My PA.
That's really the scariest part about going to Dartmouth or Mass General.
I wouldn't be. Again, I work here because I think it's better for a lot of reasons. I wouldn't be scared of it as long as you're willing to say, to make that request. The thing that I have patients tell me more often about places like that is they don't feel their care is as personal. We're not so big here that you feel like you're lost in the shuffle. I have lots and lots of patients who've had surgery at Dartmouth, for example, and then either before or after had surgery here. And to the last one, they say, I really feel like I got more personal care at Rutland, just because people are more accountable. There's less people running around. You see, me and my assistant, one or both, instead of a different person every day, a different resident, a different this, a different that. It's a little more personal. I don't know that that's better. But for some people, it's more pleasant.
Been doing,
How many years have I been doing it? I've been here for 5 years, so I've been in practice myself for 5 years. I did a fellowship for a year before that where you do, except for the patients who request that you don't, you do most of every surgery with someone basically standing there over your shoulder and doing the absolute critical parts of it, which there's a lot of leeway in what's critical and what's not.
Knee replacement, and did they compare at all?
So how many knees have I done, and have I had any patients who've had an ACL and a knee replacement? I do about 100 to 120 a year since I've been here. I did about 400 the year I was in fellowship just because it was a really busy, big place. So it depends on when you start counting. And I have lots and lots of patients who've had an ACL and then subsequently, unfortunately, gone on to wear out their knee and need a knee replacement. A knee replacement's harder.
Oh, you mean the ACL knee?
Okay. Sure.
It's related to that. How many joint replacement surgeries do we do here?
How many do we do here? How many did we do here last year, Pat? 500?
About close to 500.
About 500.
Knees and hips?
Yeah, both. There are